Dr. Das, good morning.
Sir, mute batch.
Dr. Showman, good morning. You're muted, Showman.
Am I audible now?
Yeah.
Good morning, sir.
Good morning. Today we are having two case presentation. These are mostly short cases in examination. One will be on malignant melanoma and one will be on squamous cell carcinoma. The case will be presented by Dr. Swarup Kumar Satra, who is a third year DMB resident at RKM Shiva position within the Institute of Medical Sciences. And moderator today will be Dr. Shoman Das, who is ex-associate professor of surgery at IPGMR and now is in charge of surgical oncology department at Netaji Subhash Cancer Hospital. Swarup, you present the case and we'll discuss the first case. Okay.
Good morning, respected teachers. Good morning, dear friends. My patient, Mr. X, 55-year-old gentleman, farmer by profession from Howrah, presented with pigmented swelling over dorsum of right foot for last 2 years. He was apparently well 2 years back when he noticed a dark pigmented swelling over the dorsum of right foot, which was about 1 centimeter onset, slowly growing with a sudden increase in size in last 2 months to a present size of 4 into 5 centimeter. The history of darkening in color of the swelling for last 2 months. There's itching over the swelling and brownish discoloration around the swelling for the last 2 months. There is no history of pain or bleeding or discharge. There is no history of any other swelling or pigmented lesions present. There is no history of significant weight loss or appetite. There is no history suggestive of any distant metastasis. The past history, there is no history of similar illness in the past, no history of any major medical illness, or no history of any surgery. The personal history: patient is married, consumes mixed diet, bowel, bladder, sleep, appetite are normal. Socioeconomically, patient is poor status. No history of any addiction. There is no history of any allergy to any food or medications. Parents died of natural course. 2 siblings healthy. No similar history of skin-related illness. Summarizing my history, 55-year-old gentleman presented with a painless pigmented swelling over the dorsum of right foot for last 2 years. The swelling was about 1 centimeter in diameter at onset and was growing rapidly for last 2 months to attain the present size of approximately 4 into 5 centimeter with recent darkening in color. There is itching over the local site and brownish discoloration around the swelling for last 2 months. There is no history of any other swelling or any symptoms suggestive of distant metastasis.
Okay. So what is the importance of pain in this in your case?
Sir, if the tumor infiltrates the surrounding structure, then the nerve endings may get infiltrated.
How common is melanoma to invade the deep fascia and the deeper structure?
Sir, it is less common.
Yes.
Okay. And so what is the importance of pain then?
Sir, depending on the pain, then the deep fascia or deeper structures may involve and the treatment strategy may change.
Yes, so it indicates a poorer prognosis. And
yes,
due to the rapid growth, due to the stretching, the pain can happen.
yes,
Okay. Now, you mentioned there is a change in the color. Is that how that is relevant?
Sir, the change in color is one of the signs of the changing of a benign lesion to a malignancy.
Okay. What important past history is important?
Sir, the past history, if there is any nevus present or mole present in the site, or sir, any immune suppression present.
Is there any genetic syndromes which are associated with the diagnosis you are thinking of?
Sir, xeroderma pigmentosa.
Yes, yes. Okay, I think we can move.
And then you said there is no other swelling. In a patient
Yes,
who's got a pigment in the dorsum of the foot,
Yes,
what specifically works? Where else he may have swelling?
Sir, actually, as from the history and the changes occurring in the lesion, I'm thinking about.
Where? There is a chance of regional
Sir,
node
around
metastasis. So you should ask
sir,
specifically whether we notice any swelling in the groin, or
sir,
or
yes,
there
sir.
may be some swelling between the swelling and the inguinal node. What are those called as? If you have some
Sir,
swelling in the line,
around the swelling are they're called the satellite lesion, and more than 2 centimeter from the swelling in between the groin and the area of
so when
swelling,
you ask any
those are
other
called in-transit
swelling,
lesions.
you should specifically ask. Yes, you should specifically ask whether he has any swelling in the groin, which
Yes,
might
sir.
suggest a lymph node metastasis, or any in-transit nodules.
In-transit lesions.
Okay.
Yes, sir.
Yeah. Otherwise, you said there is no metastatic symptoms.
Yes, sir.
What are the usual sites where a patient may have metastasis and patient may have symptoms?
Sir,
Melanoma.
melanoma can metastasize to sir, liver or lungs, sir. So, in case for lungs, there may be hemoptysis or respiratory distress.
Malignant melanoma is a very aggressive tumor, can metastasize to any site in the body. And you will see that metastatic lesion is divided based on the system where the disease has spread. So it can,
Yes,
if you say no, it's a distant metastasis, that means you have to ask all the symptoms which may happen because of the distant in the particular site. Okay.
Yes, sir.
Okay, fine. Okay, proceed to examination.
The general examination, patient was examined in a well-lit room with proper informed consent. Consensus allowed cooperative. ECOG score was 1. Average build. Nutrition status is average. The BMI of 20. Patient is well hydrated. No pallor, cyanosis, scrubbing, edema, jaundice, generalized lymphadenopathy. BP 130/80 in right arm supine position. Pulse is 74 per minute in right radial artery. Respiratory rate is 14 per minute. Temperature is febrile. The local regional examination, there is a pigmented swelling present in the dorsum of right foot with 4 into 5 centimeter of size, asymmetric in shape and uneven or nodular surface. There's an ulcer of around 1 into 2 centimeter present with irregular margin, non-sloping, with the floor is covered with slough, and there is brownish discoloration of skin surrounding the lesion. There is no discharge or bleeding seen, no any other swelling or pigmented lesions visible. On palpation, no local rise of temperature or tenderness palpated. My inspector findings are confirmed. Along with size, shape, surface, the consistency is firm. The ulcer base is indurated, and there is no fixity to the underlying structures. No discharge or bleeding during palpation. And lymph nodal examination on inguinal or popliteal lymph nodes are not palpated clinically. Systemic examinations are essentially normal. Now summarizing my case, sir. 55-year-old gentleman presented with a painless pigmented swelling over the dorsum of right foot for last 2 years. The swelling was about 1 centimeter in diameter at onset and was growing rapidly for last 2 months to attain the present size of approximately 4 into 5 centimeter. With recent darkening in color, there is itching over the local site and brownish discoloration around the swelling for last 2 months. No history of any other swelling or any symptoms suggestive of distant metastasis. On examination, there is a dark pigmented asymmetric nodular swelling, 4 into 5 centimeter size with an 1 into 2 centimeter ulcer with slough in the floor and indurated base. There is no underlying structures involvement or no popliteal or inguinal lymph nodes palpable. No other swelling or pigmented lesions present in the bodies.
Okay, so history we have covered. In examination, you mentioned it. He is having ECOG 1.
So, yes, sir. Sorry, sir, I couldn't hear you.
What is ECOG? You mentioned it. Patient is
Yes.
having ECOG 1 performance status. What is ECOG,
Yes,
and what is the significance? Yes, yes.
Sir, ECOG is assessing the performance status of the patient in a case of in a suspected case of carcinoma. ECOG 0 is patient is doing his normal activity normally without any problems. ECOG 1 is a slight restriction of a normal slight restriction of his activities or mild symptoms may be present, but he can perform his daily normal activities normally. And ECOG 2 is where is there is some patient can't perform his normal activity. Perform as
Two cannot perform normal activities.
cannot perform normal activities, but can perform his daily activities. And 3, a patient needs help from others to perform his daily activities, and 4.
What are the other performance scales you know of?
Sir, Karnofsky performance score is there, sir. In Karnofsky performance score, it's scored from 100 and below downwards, sir.
Okay. So what is your provisional diagnosis?
Sir, my provisional diagnosis, 55-year-old gentleman with dark pigmented swelling over dorsum of right foot, probably of malignant etiology, most likely a case of malignant melanoma without any lymph node metastasis.
Why are you saying this is malignant melanoma?
Because a dark pigmented lesion present in the legs, and it has some malignant changes, which indicates the maybe it's a case of malignancy.
What are the malignant changes?
Sir, the asymmetricity, itching, and also present over the swelling, and the darkening of the skin color around the swelling, sir.
What is ABCD of malignant melanoma?
Sir, ABCD is the self-assessment for the patient for to look out for any changes of a benign lesion to a malignant lesion. A stands for asymmetricity. B stands for the irregular border. C stands for the any color changes present there or not. And D stands for diameter more than 6 millimeter or depth. And E stands for any evolutionary changes or elevation of the nodule of the swelling of the lesion.
What are your differential diagnoses?
And before proceeding, Shoro, you
Yes,
said
sir.
a malignant melanoma, but in the history you try to say that there is a pigmented lesion which was static for 2 years and it started increasing in size for last 2 months only. So I would prefer to give a diagnosis that this is a malignant melanoma developing on a benign nevus, because you have seen all the changes which has come up. I think that should be a better diagnosis instead of saying that it is because in 2 years it was not growing. You said it don't only last 2 months.
It's slowly growing, sir. In the initially it was slowly
that?
growing. Okay, sir.
Achha. It is slowly growing. Okay.
What are your differential diagnoses?
Sir, my differential diagnosis will be, sir, squamous cell carcinoma or pigmented BCC, or sir,
I cannot hear you.
sir?
Pigmented BCC, you said. Pigmented BCC.
Yes.
And there is no lymph node, there is no transit nodule. Can it still be a benign lesion?
So it can be, but the malignant changes which is occurring is suggesting towards the malignancy. So we need to confirm.
Okay, how will you confirm your diagnosis?
Sir, confirming my diagnosis, I'll go for an full thickness biopsy, sir.
Full thickness biopsy from how you are going to take the biopsy and from which area you are going to take? Are you going to do an excisional biopsy or an incisional biopsy?
So I'll go for an incisional biopsy, sir. Edge-wedge biopsy I'll go, because the edge portion. Because sir, edges of the lesion are the most proliferative part of the lesion, and as there is ulcer present in the, so I may get necrotic tissue in the center. So edges will show the proliferative changes.
Okay. Would you like to include the full thickness of the skin in your biopsy, or a superficial biopsy will do?
Sir, I'll go with full thickness biopsy to check out
why that is necessary. Your diagnosis can be taken from superficial biopsy also.
Sir, because according depending on the depth of the lesion, the treatment plan may change.
How the depth changes your treatment plan?
Sorry, sir.
How depth is going to change your treatment plan?
For sir, if it is in situ cancer, then the border, the margin, safe margin will be 5 millimeter, and if it is less than 1 millimeter of thickness, then it will be 1 centimeter, sir. And if it is more than 1 millimeter, then it will go for 2 centimeter adequate.
2 centimeter macroscopic margin. Okay. Is there any gradation system based on depth of invasion?
Yes, sir. On the depth of invasion, there is the breast dose.
Breast fluid is what? Breast fluid is thickness.
Sorry,
Breast
sir?
fluid based on thickness of the lesion.
Yes, the thickness of the lesion.
And
Clark's level is for on the depth of invasion, sir.
Right.
Invading the layers of skin.
So Clark is an histological diagnosis where based on the level of invasion, you can grade them.
Yes, sir.
Okay. So after you have done a biopsy, incisional biopsy from edge, what other investigation you would like to do?
Sir, as there are no clinically palpable lymph nodes, and as an extension of my clinical examination, I'll go for USG of the inguinal region to check out any radiologically detectable lymph nodes present there or not. And after that, after that, other routine investigations I'll go for operating the patient, sir.
How will you do metastatic workup?
Sir, if there are lymph nodes present, then we'll go for CT, abdomen, and pelvis. Because USC.
the question is, will you do a routine workup for all patients of melanoma for a systemic metastatic workup? You started answering. Either lymph nodes are palpable, and if in radiology evidence of lymph nodes are metastatic, then there is a possibility of distant metastasis. Otherwise, a routine metastatic workup is not essential in all cases.
If lymph nodes are not evident, then routine metastatic workup are not done.
All right. So USG is showing there are no inguinal nodes. Now, what is your plan?
So according to the depth of invasion, I'll go for a surgical workup, and after working up, I'll go for a wide local excision of the lesions. According to depth, I'll get the margins.
Okay. This lesion is in the dorsum of foot.
Yes.
He has a 5 centimeter lesion. How will
Yes.
you close the lesion?
So I'll close after excision of the lesion, I'll close the lesion with the split thickness skin grafting.
Skin grafting. Okay.
If it is the sole of the foot, if this lesion was in the sole of the foot, what would have been the preferred?
In case of sole of the foot, as it's a weight bearing area, I have to cover it with flaps.
Okay. What is your planning on lymph nodes? Would you like to do something else, even if your ultrasonography is normal?
Clinically, ultrasound N0 node. What is the strategy for lymph node dissection in melanomas?
So I'll go for sentinel lymph node biopsy. If it comes negative, then I'll stop there.
How will you do sentinel biopsy in melanomas?
For sentinel lymph node biopsy, yes, for sentinel lymph node biopsy, the preoperative lymphoscintigraphy with technetium colloid sulfur peritumoral injection is given, and
sentinel node biopsy you will be doing in the operation theatre. It's not listened to.
Yes, sir.
You will be doing sentinel biopsy in the theatre. What is the technique? Okay. One is dye technique. One is dye technique. Second.
Sir,
one is dye technique. Inject dye and look for a dye.
And second one is a gamma camera. Sir.
Gamma camera. What do you inject?
Sir, technetium colloid sulfur.
99 technetium sulfur chloride.
Sulfur chloride.
And use a use a probe.
It's a gamma
Which is
probe.
the new innovation. People are now using another new gadget to do sentinel biopsy.
So I don't know that.
This is
ICG.
ICG.
Oh,
Okay.
intercell gains.
Yes,
Intercell
you
gains.
can instant gain, and you can real time trace the lymphatic flow to the node. Okay, that is a new innovation. Now you have a camera, a special camera which can image this node, and you can detect the sentinel node by doing this ICG imaging. Okay, so you should mention that also. In addition to this, and combined technique was the blue dye and the sulfur colloid.
Okay, sir.
What are the other cancers where you do sentinel node biopsy?
Sir, in case of sir, breast cancer
and
sir, penile cancer.
yes. And
Correct.
now people are also doing in head neck cancer, also people are doing, but not very popular.
Yes. So suppose you have multiple in-transit lesions or multiple
Yes.
skip lesions, then how will you manage the case?
Sir, if the skip lesions are less than 3, then we'll go for surgical excision. If it is more than 3, then we have to go for limb perfusion or infusion therapy, sir. Hypothermic limb perfusion therapy with melphalan or limb infusion therapies.
How that is done?
Sir,
You mean isolated limb perfusion? It's a form of what?
isolated
Chemotherapy. It's
Yes,
a form of regional chemotherapy.
regional chemotherapy, sir.
So how it is done? Is it isolated limb perfusion? What does it mean?
Sir, tourniquet is applied, and then the actual process, sir.
No.
So,
It's not tourniquet. No. You
Yes,
should
sir.
read it. This is done by a extracorporeal oxygenator. You
Yes, membrane
cannulate the
oxygenator,
femoral
sir.
artery and the vein.
Yes.
You cannulate the femoral artery and the vein.
So then,
So
sir,
what is
for the
done?
venous corporeal membrane oxygenator, the blood is passed, and then the chemotherapy is applied, and then the blood is put back in by the arterial loops.
Yes.
So the basic concept is you are instilling the chemotherapy through the artery and you are
Yes.
taking it back through the vein. So that the lower limb, that part of the limb gets drenched with chemotherapeutic agent. It's a form of regional chemotherapy.
Yes, sir.
Okay. And what is the role of amputation in malignant melanoma?
Sir, if the malignant melanoma invades deep to the deep fossa, or if it invades the bone, underlying bone or bony structures, then there is a role of amputations.
Yes, extensive disease with involvement of bone and etc., not amenable to reconstruction. Okay. What are the markers? What are the IHC markers which are positive in melanoma? Because at times it is very difficult, especially the amelanotic melanoma.
Yes,
they will not have that dark pigmentation. There, the differentiation is done by doing immunohistochemistry. So, what
Yes,
are the markers that are positive for malignant melanoma?
Sir, S100, HMB 45,
Yes, and vimentin.
Vimentin.
How do you differentiate it from squamous cell carcinoma?
Sir, by IHC.
I see.
Yes.
Cytokeratin.
Cytokeratin 1 and 10 for squamous cell carcinoma.
Yes. Okay. What is the role of systemic therapy in malignant melanoma?
There is newly invented systemic immunotherapy present and targeted therapy are present, sir. And
basically, are they radiosensitive, chemosensitive?
No, sir. Malignant
melanomas?
melanoma are not radio and chemosensitive, but when the lesion is not amenable to surgical reconstruction or surgery, or in such cases, or in where there are lymph nodal metastasis present, in those cases.
So the role of systemic therapy
And
meaning, yes. So the number one role of systemic therapy or immunotherapy or targeted therapy is a metastatic disease.
Yes,
There
sir.
is no role of surgery in metastatic disease other than palliative setting. Suppose a patient is having bad wound, foul smelling discharge is coming. In spite of having multiple metastases, you can operate on the patient, but just only to get a quality of life, not to get a survival benefit. This is number one.
Yes, sir.
Number two is in adjuvant setting. Adjuvant setting, there is some role of radiation, where in adjuvant setting where you have operated, reoperation is not possible and your margin is positive.
Positive. Yes, sir.
Number three, when you have done a lymph nodal dissection and there is huge burden of lymph node, there adjuvant radiation is indicated. All right.
Yes, sir.
Okay. I think
What are the different chemo regime you advise for melanomas? We don't need details, but at least some names which are said to be effective for melanomas.
Yes, sir.
Previously, it was single drug chemotherapy.
Yes, sir.
Drug is
Melphalan-
dacarbazine.
Dacarbazine. Now, sir,
Now
CVD
there is
regime,
also
sir. CVD
combination.
regime.
Yes.
Cisplatin, vinblastine, and dacarbazine.
right. These are melanomas are actually very aggressive tumor. What is the commonest site of melanoma?
Sir,
And what is the
Sir,
commonest site?
sir, sun-exposed areas are the commonest site, like extremities. You can be
So
there.
where are the sun exposed areas? So if you take a normal person, sun exposed
Yes,
areas and
sir.
the extremities.
Head, neck areas and extremities mainly, sir. And commonest type
Any
is,
other
sir.
site? Any other site apart from skin? Apart from
Sir,
skin,
yes, sir.
any
Apart
other
from
site for
skin,
melanomas?
sir, it can be present even in the eye, sir. Choroidal melanoma, sir. It can be
Yes.
present in anal canal, sir.
Mucosal melanomas.
Yes.
What are the
Mucosal
clinical
melanomas.
variants of malignant melanoma?
Sir, clinical variants, it can be superficial spreading types. It can be, sir, lentigo maligna types. It can be acral lentiginous types.
And another variety
Amyloidic melanoma and desmoplastic.
there is
And
another is
nodular
nodular
Nodular types.
Which one is most malignant one?
Sir, nodular types.
Yes, because if the
Vertical growth.
nodular will have a vertical growth.
Yes, sir.
Since the vertical growth is there, it spreads very quickly. Okay.
Yes, sir.
There is a peculiarity about the last one. Acha, which one is less aggressive?
Sir, superficial spreading type.
No, superficial spreading type is the commonest
Most
one.
common. Yes.
Lentigo malignant type is the it is less common. It is
Yes,
less
it is.
common. It is in later age group and it is near the lens. Lens means that is how you remember L for L, isn't it?
Yes.
Lens means it is in the face.
Yes.
Okay,
Yes, sir.
fine. So desmoplastic variety will have a peculiarity.
Yes, sir.
That-
Perineural invasion.
Perineural invasion, right? So all desmoplastic varieties, after you excise, you will have to give a radiation in the bed because
Yes.
there is perineural invasion.
Yes.
Okay,
Adjuvant
done.
radiotherapy.
Swaroop, in TNM classification of the melanomas, what is
Yes, sir.
taken into account
Yes.
to classify into T1, T2, T3, T4?
Sir, in T staging, the depth is taken into account, sir. The depth of 1 millimeter and
Tumor
or
thickness.
less is T1, 1 to 2
It's
is
tumor
T2.
thickness. Tumor thickness.
Tumor
Yes.
thickness. Sir. Tumor thickness. 1 to
And
2
what is
is
taken into consideration for end staging? Only the
Sir,
lumen or something else?
end staging or M.
Yes, end staging.
End staging.
Node.
End staging is sir, size is taken, sir.
No. Apart from lymph node, anything else is also included?
Sir, clinical, sir, high risk
Intrinsic.
factors, sir, high risk
No,
factors.
Node
sir, sorry.
of intrinsic
What
nodules.
about the in-transit nodules?
So intrinsic nodule, sir, that is C. Sir, N1A is not detected clinically, detected by lymph node biopsy. B is clinically evident, and C are intrinsic nodules.
Right.
And,
So A is sentinel node biopsy.
Yes, sir.
And what about metastatic disease? Is again divided into M1, M2, M3.
Yes, sir. M1, M2, M3, M1, M2. Sir, M1, A, B, C, D, sir, are there. When 1A is when skin and surrounding metastasis to skin or surrounding tissues. B is when metastasis to lungs. C is for other visceral structures, and D is for CNS, metastasis to CNS.
C is for
And sir, LDH level is also considered.
Okay, I think we can pass on to the squamous cell carcinoma. Next
Yes,
case.
yes.
So my patient, Mr. Das, 37-year-old.
Change your slide. Change your slide. Change your slide. It's a previous slide only.
Oh, previous.
Just pass on the next slide.
So I'll re-share again, sir.
Yeah.
So is it visible now? Sir?
Yes.
So my patient, Mr. Das, 37-year-old gentleman, hawker by profession from Midnapur, from a low socioeconomic status, presented with a swelling over upper part of chest for last 3 years. So apparently, 3 years back, noticed a small swelling over the sternal region over the manubrium sterni, which was gradually growing with a sudden increase in size with central ulceration in the past 9 months to a present size of 5 into 7 centimeter. With a serous or seropurulent foul-smelling discharge, the lesion was not painful. There is a history of prolonged sun exposure because of his profession. No any similar lesion anywhere else in the body. No history of trauma or any previous operation on the site. No history of any immune suppression or radiation exposure. No history of significant weight loss or appetite. No history suggestive of any distant metastasis. No history of similar illness in the past. No history of any major medical illness being treated by QAC for the same disease. No history of any surgery. On personal history is married, consumes mixed diet, bowel bladder, sleep, appetite are normal. No history of any allergy to any food or medications. So I forgot to add the addiction, but there is no history of any addiction. Father died of natural course. In family history, his father died of natural course. Mother and 2 siblings are healthy. No similar history of skin-related illness.
Give the summary at the end. Pass on to the examination.
So patient was examined in a well-lit room with proper informed consent, conscious, alert, cooperative, thin build, average nutritional status, BMI of 19, well hydrated, no pallor, cyanosis, clubbing, edema, jaundice, or generalized lymphadenopathy present. BP is 120/70 in a right arm supine position, and pulse is 88 in right radial artery. Respiratory rate is 14 and temperature is febrile. So this is a picture. On local regional examination, there is ulcer proliferative growth seen in the sternal region over manubrium sterni, extending superiorly just above the sternal notch and inferiorly just below the manubrium sternal angle. Of 5 into 7 centimeter size with irregular shape and uneven surface. There is an ulcer present with irregular margin, rolled out, everted edge, and floor covered with necrotic tissue. There is no redness or shininess noted in the surrounding skin. The discharge present was seropurulent, foul smelling, no any other swelling visible. On palpation, no local rise of temperature or tenderness palpated. Inspectory findings are confirmed. Site extent, size, shape, and surface, along with all those things. The consistency is found to be firm. It is not fixed to any underlying structures. The ulcer is present with irregular margin, rolled out, everted edge, and floor covered with necrotic tissue. I couldn't appreciate the base. No regional lymph nodes palpated clinically. The systemic examination were essentially normal, sir. Now, summarizing my case, 37-year-old gentleman presented with a swelling on the sternal region of chest for last 3 years. The swelling was rapidly increasing in size for last 9 months with central ulceration and serous or seroprudent foul smelling discharge. On examination, there is an ulcer proliferative swelling of 5 into 7 centimeter on sternal region over manubrium. The swelling with central ulceration is irregular in shape with rolled out everted margin and necrotic tissue over the floor. Swelling is not fixed to the underlying bone. Regional lymph nodes are not palpable. No other swelling present in the body.
Okay, you mentioned in your past history that there is no similar kind of history. What else you encounter in past history? What is important?
Sir, any history of any operation or trauma?
How that is relevant? Which operation? Which kind of trauma?
Sir, or any burn scar is present there or not?
Yes. So one is a burn history of burn.
Yes.
Why that is important?
Because sir, chronic scar of burn may present as marjorin's ulcer, which may convert to squamous cell carcinoma.
Squamous cell carcinoma, right? What is the peculiarity of marjorin ulcer?
Sir, it's present as it presents after a long time, sir, and there is no pain or lymphatic spread unless until the scar tissue is crossed by the growth.
Rate of growth?
Because it's already scarred, the
Yes, sir.
lymphatics
No
and neural damage is there, pain is not there, and it is slow growing, right?
Yes.
So burn is one important history. Another,
Yes.
you mentioned trauma. Which kind
Yes.
of trauma is important? Not
So
for
which
your
kind?
location of tumor, this location of tumor, other sites of squamous cell carcinoma. Say, for example, oral cavity. Say, for example, buttock area.
Chronic irritating trauma or
Yes.
Chronic
irritation,
repetitive trauma.
repeated trauma, sir.
Okay, right. You did not mention
Clinical
about
part.
neurological
Clinical part,
symptoms.
yes. Clinical part, you said you cannot appreciate the base of the ulcer. What do you mean by base of the ulcer?
So base of the ulcer means the over which the ulcer lies.
So you said the ulcer is mobile, not fixed on the underlying bone. So that is what you appreciated. Base of the ulcer, if you can move it, that means
Yes.
the base is free. It is not, you see, there is nothing deep to the skin here. Deep to the skin,
interior
the skin is what? Only the bone. And if you take lateral side, it might be some pectorals coming up. So if you can move the ulcer,
Okay, sir.
then the base is not fixed to the underlying bone, because you commented at another point.
Yes, yes, sir. It's not fixed to the underlying structures, but
And you
induration,
said
I
regional
cannot
lymph
palpate
nodes are
actually.
not, regional nodes are not palpable. Which nodes
Yes,
you
sir.
have palpated in this patient?
So in this patient, I palpated the axillary nodes, sir.
Cervical? Because it has gone above the suprasternal notch.
It's not above the suprasternal notch, so cervical nodes are
It is. You see,
not that
you
much
see,
relevant.
the swelling has gone above the suprasternal notch. So you have to examine both the cervical and the axillary nodes in this patient.
Okay,
It's in the
sir.
midline. So you can
Okay,
go
sir.
to the ideal site.
Okay, sir.
And it is extending almost root the neck. So you should examine both the lymph nodal field here. Your description is good, but clinically you should be conversant that what you are commenting about.
Okay, sir.
What is the difference between floor of ulcer and the base of ulcer?
Sir, floor of ulcer is what we can see in inspection, and base of ulcer is what we can palpate or over which the ulcer lies.
And why this ulceration occurs at the center? Once a tumor grows, you see the ulceration usually occurs in the center. Why?
Sir, because the tumor tissues overgrow the vascularities.
Right. Once a tumor grows, the central portion, they suffer from vascular insufficiency because the vascularity maximum neovascularization occurs at the periphery because the growth is there at the periphery. Right. You did not mention about the neurological symptoms associated with the lump in the peri-lump area. Neurological symptom includes pain, numbness, and etc. around the swelling. Why that is important?
Pain is not present there. Pain was not present there, sir. But numbness, I didn't take the history, sir, about numbness.
Because direct invasion of nerves, as well as if the tumor is having perineural invasion, then it can affect the nerve. So that history actually indicates a poor prognosis.
Yes.
And that guides you that this patient will require postoperative radiotherapy. That's a surrogate marker of that. Okay. So again, how we would like to confirm your disease diagnosis?
Again, I'd like to do an age-based biopsy, sir, to confirm my disease.
Full
After,
thickness biopsy
confirming-
from the age.
What do you find
Yes, sir.
histologically? What is the typical histological appearance of a squamous cell carcinoma? Typical histological appearance? What do you
Sir,
find in the microscope?
sir,
It's classically described as what?
presence of keratin pulse.
Keratin and what is there? The center there are hyperchromatic cells.
Yes, sir.
These are described as in typical squamous cell carcinoma, you will find this appearance. And based on that, you classify this tumor into well differentiated or poorly differentiated.
Okay, sir. Yes. That's the broader classification according to keratin pulse.
Yes. And there are some high risk features. There are some high risk features which
Yes,
are
sir.
taken into consideration now in TN association also.
Yes, sir. Sir, the high risk features include the depth, which is more than 6 millimeter, and then the grade, the histological grade that according to the broader classification, and the histopathological histopathology of perineural invasion or lymphovascular invasion present there or not, and the site like ear lobule and lips are more aggressive in nature. These are the high risk features.
Okay.
Okay. What else investigation you would like to do?
Sir,
How metastatic workup is done?
sir, I'll as an extension of my clinical examination, I'll go for an USG of bilateral axilla and neck.
For your
And,
patient, it is
what is
more
the
than 5
characteristic of
centimeter
it?
tumor.
Yes.
For your patient, more than 5 centimeter tumor. What staging investigation on metastatic workup you will do? So more than 5 centimeter is a high risk criteria, isn't it?
Yes, yes, sir.
So what would you like to do? Metastatic workup?
So I'll go for CCT chest and abdomen, sir.
Yes, that can be done. In your case, I think it merits a PET CT scan. It's a large tumor. Although you mentioned lymph nodes are negative, but
Yes,
still, such a big tumor, a PET CT can be done. CT thorax abdomen pelvis is also justified, but a
Yes.
CT at least is required. Only a chest X-ray and ultrasound will not do in your case.
Yes, sir.
Okay.
Yes, sir.
What are the
Right.
characteristics
Then
of lymph node on ultrasound which are metastatic?
Yes.
Sir, characteristic of lymph node changes in ultrasound. First
Size?
is sir, size.
Which size is significant?
Size in case of inguinal region, it is more than 1 centimeter is clinically significant, and if in other cases more than 6 millimeter or 7 millimeter and 7 millimeter and more are clinically significant.
Fine, size.
Then
What else?
Then
What
shape,
other features? Other
Shape.
features.
shape, sir.
Yes.
Shape, usually normal lymph nodes are kidney shaped or reniform shaped. It may change. It changes to oval or round shaped. Then the presence of due to presence of central halo is due to medulla. In case of malignant changes, the central halo is lost, sir. And the differentiation between the lymph node and the peripheral tissues, there is a peripheral halo present that will be lost. Then if there are any capsular breach, capsular invasion, it may be seen in ultrasonography, sir. There may loss of fatty hilum.
Outline of the node. Outline will be irregular. Outline of the node
Outline
will
will
be
be
irregular.
irregular, sir.
Yes.
There will be loss of fatty hilum, sir.
Yes. And
if we apply Doppler mode, then there will be hypervascularity.
yes. You should keep in mind what are the important metastatic features in node in imaging. That is often asked in the examination. Okay.
Yes.
So how will you manage your case?
Sir, as it is more than 2 centimeter, then I'll go for 2 centimeter margin wide local excision, and I'll go for a central lymph node biopsy.
In well differentiated tumor, in well differentiated squamous cell carcinoma, what is the optimal margin? Because if you see large and go 2 centimeter more on all around, you make a big gap. What is the recommendation for squamous cell carcinoma? Is it well differentiated, or
if it is well differentiated or low grade tumor, then we can go for a 4 millimeter margins.
4 is less.
But as the size is big, so then 2 millimeter margin is 2 centimeter margin is
too less.
Okay, so what is your opinion on reconstruction of this case? What is better, a flap or a skin graft?
Sir,
Because it is over the sternum.
over the sternum, though it's over the sternum, then also I'll go for a skin graft, sir.
So the issue of skin graft in squamous cell carcinoma is squamous cell carcinomas are not like malignant melanoma. So they have a role of adjuvant radiation there. Okay.
Yes.
So here, when I am planning for an adjuvant radiation, what are the indications of adjuvant radiation where you will give radiation after the operation?
Sir, margin positive, if there is margin positive.
Now, don't touch the first part, which is controversial. Margin positive again may need surgery. So it's clear indications. Large tumors more than 5 centimeter.
High grade tumors.
Yes.
High grade tumors, lymph node positivity, sir. Depending on the area of lymph node, presence of lymph nodes.
High grade tumors with poor prognostic factors.
Yes, sir.
Right.
Yes,
and if it is margin positive, the one strategy is to go for re-excision. And if re-excision is not feasible, then you can go for a radiation. So these are the role of adjuvant radiation. Is there any scope of primary treatment of squamous cell carcinoma with radiation?
Sir, primary scope.
Single modality treatment without going for surgery?
Mention sites where
head and neck, sir. So in head and neck squamous cell carcinomas, we can go for radiation therapy, sir. And in small lesions also we can go for radiation therapy.
Yes, very small lesions in lip can be treated. Very small lesion in lip can be treated with brachytherapy. Brachytherapy is a form of radiation therapy. And base of tongue. You know, at the base of tongue, if you have a squamous cell carcinoma there, it becomes very difficult to do it surgically. You need to remove the whole of the tongue. So total grossectomy with reconstruction, patient will have a permanent damage. There you can treat these patients by giving radiation, chemo radiation. Vocal cord squamous cell carcinomas, they are curable with radiation, isn't it? So these are the areas where you can cure the patient with single modality, or maybe you can add chemotherapy along with radiation without surgery.
So in high lymph node burden or fixed lymph node burden to change the mobility,
yes, so,
the radiation therapy may change the mobility.
That is for adjuvant, in the adjuvant setting. After you have taken care of the primary as well as you have dissected the nodes, then you go for adjuvant radiation if the nodal burden is high. All right. Okay. Now, what are the pre-malignant lesions of squamous cell carcinoma?
Sir, pre-malignant lesions of squamous cell carcinoma include, sir, actinic keratosis, solar keratosis, keratoacanthoma, radiation keratitis, xeroderma pigmentosa, old burn scar, chronic irritative traumas, and leukoplakia also.
What is Bowen's disease? What is Bowen's
Bowen's,
disease?
Bowen's disease or erythroplasia of Poirot's.
What it is? What it is? Bowen's disease is what? It is basically a commercial carcinoma in situ.
Yes, sir.
Okay, and then it may become invasive afterwards.
Yes.
What is the strategy for these pre-malignant lesions? If your patient has suppose it's a head neck squamous cell carcinoma, patient has cancer at one side and a pre-malignant lesion on the other side, what should be your strategy? Do you want to operate both?
Sir, biopsies.
Yes,
Biopsy has shown that lesion. Biopsy event is one part, but what is the treatment for that pre-malignant lesion? Apart from excision, there are some other modalities of treatment.
Sir, systemic therapies.
Systemic therapy is not recommended for in situ lesions or pre-malignant lesions.
Sir, cryotherapy and derm ablation therapy, sir. Yes. Cryotherapy with liquid nitrogen.
Yes, cryotherapy, laser ablation. These are the options which are applicable for these pre-malignant lesions or lesions other than the primary.
Electrodesiccation. So there are some, these are less invasive treatment.
Yes.
Okay, so you have your patient, you have operated on the patient and you have done a flap and patient receives radiation therapy. What is the role of systemic chemotherapy in squamous cell carcinoma? Number one is metastatic.
Yes.
When you have metastasis, multiple metastases there. Number two, Acha, tell me, how do you manage multiple cancers? Because squamous cell carcinoma can have multiple sites.
Yes, sir.
One lesion here, another lesion there, especially where? Especially patients with immunosuppression.
Immunosuppression.
Post-kidney transplant patients. They may have multiple cancer lesions. How do you manage them?
Sir, systemic, I will go for systemic therapy in those patients.
See, these patients are very nutritionally poor. They have a post-transplant status, already immunosuppressed. So they are giving systemic therapy is more riskier. So again, the treatment plan remains the same. Even if it is multiple, there, if surgery is feasible, that is the primary modality of treatment. Okay. If surgery is not feasible, then a safe systemic therapy like chemotherapy and etc. can be given. So that is how you manage. And this is really common in post-transplant patients. Okay.
Yes.
They may have multiple cutaneous squamous cell carcinomas. Okay. Now, how do you follow up your patient?
Sir, for following up this patient, I'll do a regular follow-up of 3-month basis. Sir, generally as squamous cell carcinoma needs follow-up for 5 years.
Yes, NCCN recommends 5 years follow-up.
5 years.
3 monthly for 2 years.
3 monthly for 3.
Yes, yes. Then
6 monthly for
6
next
monthly.
remaining years.
What do you do in each visit? What is your protocol for each visit? This patient has got a chest wall SCC. When he come back to you, what do you like to see? You have not treated the lymph node. It was N0. So what you see in each visit?
Say any other swellings or lesions present.
First, think of the local site. First, see the local site. Any evidence of local recurrence? Any appearance of lymph nodes? These are the two primary concerns. You see, the squamous cell carcinoma spread to distant site very Rarely.
Slowly.
So a distant metastasis from squamous cell carcinoma is not very common. Mostly
Yes,
it is
yes.
local recurrence and the lymph nodal metastasis. So in each visit,
Yes.
you should take a history, you should examine the site, and if
Okay,
need
sir.
be, you can order for a ultrasound.
Okay, sir.
So during follow-up, if you find a local recurrence, how do you manage that?
So plan for reduce surgeries
Yes.
after
So,
Yeah, when you get a local recurrence, this is a situation where PET scan is kind of mandatory thing. Once you get a local recurrence, you must see that the recurrence is only locally present or it is a systemic recurrence is there. Because
Yes.
if you see a systemic metastasis, then plan becomes palliative, you know. So
Yes.
if you get a local recurrence which is resectable, you resect again and reconstruct that area. If
Okay,
the
sir.
local recurrence is at nodal basin, what is the
Sir,
treatment there?
I'll go for radiotherapy first, sir.
why? Mobile node? You divide.
If it is mobile
If
and
you divide, if your lymph node spread, you do imaging and do clinical examination to assess the lymph nodal stage.
okay, sir.
In mobile lymph nodes, again, you have options for radiation and surgery, but surgery is preferable.
Okay, sir. Which imaging modality is better to pick up recurrence in presence of flap? Suppose you have done a flap here, you are following up the patient. There are some nodularities, indurations you are feeling beneath the flap, which you cannot see. So,
MRI.
ultrasound is good enough, or you want to do something else?
Say MRI.
Yes. So first I'll do an ultrasound, and
Yes.
all recurrences are to be histopathologically proven. So if you have a recurrence, you must do an ultrasound guided core biopsy to confirm that yes, I'm having this patient is having metastasis. And sometimes this problem solving modality MRI is done to see whether it is a scar tissue post-op fibrosis versus a recurrence or a disease. Right? So in nodal metastasis also, if it is isolated nodal metastasis, there are no systemic metastasis, and you have mobile nodes which are resectable, you go for a neck dissection if it is in the neck. Okay?
Okay, sir.
Okay.
All right.
We have covered almost little about anatomy of the skin. You see, squamous cell carcinoma, basal cell carcinoma, malignant melanomas all arise from the skin.
Yes,
what are the different layers in the skin you are talking of, the invasion? What are the different skin layers?
Sir, skin generally consists of epidermis, dermis, and subcutaneous tissue, sir.
Subcutaneous tissue. Yes.
Epidermis, it comprises of 5 layers, sir.
Yes.
Stratum corneum, stratum.
Recording in progress.
Sir, lucidum, stratum corneum, stratum lucidum, stratum granulosum, then the malphizian layer or spindle cell layer, and the vessel layer. And dermis consists of 2 parts, papillary dermis and reticular dermis. In case of in case of malignant melanoma, it generally arises from the basal cell layer or the malphizian.
Yes.
Cell layer.
This anatomy is important because the depth of invasion you are talking of, the Clark's level, all are based on this invasion to the different layers of the skin.
Yes, sir.
Okay, I think 9 o'clock. Dr. Das, you can.
Yes.
Thank you.
Thank you.
Sure. You answered well.
Thank you very much, sir.
Okay, you are ready for exam. Fine.
Thank you, sir.
Thank you. Dr. Boshak, any comment?
No, good discussion. Only one thing we missed initially is the Clark's level and Bessels level, which you have included later on.
Yes.
Clark's level and Bessels level, we have to know. Great discussion. Thank you.
Thank you, sir.
Thank you.
Thank you.
এখন তো ঠিক একবার জিজ্ঞেস করে